which are seen exclusively in young women. Located mostly in the body and tail of pancreas, most common presentation would be abdominal pain followed by abdominal mass. Microscopically, it is a mixture of solid pseudopapillary and hemorrhagic pseudocystic areas. The treatment is mostly surgical, although 20% of the cases would present with metastatic disease. However, despite this, the advanced survival, even after advanced disease, the survival is good after 5 years, up to the tune of more than 95%. This is a T1 weighted image. It shows a well circumscribed pancreatic head mass with focal areas of high intensity, which is corresponding with hemorrhage. Now, contrast enhanced T1 weighted image shows the pancreatic head mass as well as a non-enhancing cystic region over here. And T2 weighted image, the non-enhancing cystic areas, they become hyper intense. So, to summarize the major demographic characteristics of all the pancreatic cystic neoplasms, if you look at age, 40 to 60 is the most common age for presentation. The gender distribution is predominantly towards the female. Some, like IPMNs or pseudocysts, will have a communication with the pancreatic duct. Also, fluid CA, they will be elevated in those which are mucinous in origin. They will have high CA levels. Fluid amylase, which will be high in those cystic neoplasm which have a communication with the main pancreatic duct, like IPMN or maybe pseudocyst. Most of them are solitary in nature. However, IPMN can be multifocal, and almost all of them, apart from serous cystic neoplasm, have some or the other tendency of malignancy. Now, coming to what is the role of blood and cystic biomarkers in the diagnosis and follow-up of PCNs in current clinical practice. Now, mucinous pancreatic cystic neoplasm, they usually contain a high viscous cystic fluid. The string sign, which is which consists of placing a drop of cyst fluid between your cyst fluid aspirate between your thumb and index finger and then stretching it. It has got a high sensitivity for detection of a mucinous cystic neoplasm. Cyst fluid which is obtained during US FNA is usually acellular, and therefore cytology itself does not have that much sensitivity. This combined with cyst wall cytology increases the diagnostic yield up to 30%. Now, CEA, mucinous PCNs are usually lined by endoderm derived columnar epithelium secreting cells. So, CEA will be secreted in mucinous cystic neoplasms. So, these have got a good, fairly discriminative value for differentiating between mucinous and non-mucinous origin. Amylase, it has got role only in excluding pseudocyst. Now, what is the role of DNA testing? Mutations which are detected in KRAS or GNAS are highly sensitive and specific for IPMN, but not MCN. And 100% of the patients with IPMN are going to have KRAS and GNAS mutations. Mucinous cystic neoplasm, only up to 30% they are going to have. However, this has not been translated into clinical practice yet because of cost effectiveness, and studies and pilot studies are still going on. More research is needed into this. So now comes the main question: what is the role of endoscopic ultrasound? Now, according to all 4 guidelines, EUS is recommended as an adjunct to other imaging modalities. EUS is helpful in identifying PCN with features that should be considered for surgical resection. Indications include if the cyst size is more than 3 cm, PD is dilated, presence of a solid component, mural nodule, if there is associated pancreatitis, lymphadenopathy, elevated CA99. So whatever characteristics which are present, which are going to help you guide whether the patient is a surgical candidate or not, that diagnostic dilemma is solved with the help of EUS. So that is not a primary modality, it is an adjunct modality. This is a EUS image showing a serous cyst adenoma with cystic spaces and intervening septa in between. Again, an EUS image. It shows a branch duct IPMN with a calcified mural nodule which is consistent with the CT scan findings. So now, how do you increase the diagnostic yield of EUS? When should contrast harmonic enhanced EUS be performed for PCN, and does it alter management? The answer to this is yes, it does. It should be considered for further evaluation of mural nodules. It is helpful in assessing the vascularity within the cyst and septations. The presence of hyperenhancement of a mural nodule, solid mass or septations raises concern for malignant transformation. So in theory, small neoplastic solid components should exhibit some signs of vascularization as compared to debris and mucin plugs that are considered to be as completely avascular. Now, this is a contrast enhanced, this is a EUS image which is showing some amount in the head, cystic lesion in the head which is showing some amount of solid component. On contrast, there is enhancement of this nodule which is clearly seen. So, this raises the suspicion of malignancy. Now, this is another lesion in the body of the pancreas which shows fair amount of echogenic material. However, it is not, there is no enhancement which is seen on administration of contrast. So, clearly we can differentiate. So, contrast enhanced EUS shows no significant differences between the enhancing patterns of the cystic walls per se and septae of mucinous and non-mucinous PCNs. However, contrast enhanced EUS appears to be a sensitive and specific adjunct in the differential diagnosis of intracystic solid components to detect malignancy. Same example, you have got a solid component which is present inside the cystic neoplasm, does not enhance on contrast, virtually rules out any malignancy. Over here, there is enhancement with contrast, raises suspicion of malignancy. Now, what are the advances in EUS FNA cytology and EUS through the needle biopsy forceps? Now, these were used to increase the diagnostic yield of EUS FNA. Now, normally, through the needle biopsy forceps has been introduced as a novel approach for EUS guided tissue acquisition. These forceps with an outer diameter of less than 1 mm can be passed through the 19 gauge standard EUS needle to obtain biopsy specimens of the cyst wall or the mural nodules per se. Up to 4 biopsy forceps are considered as adequate. However, experience with this sampling is limited to case studies and pilot studies, and it has yet not been translated into clinical practice and into the guidelines. Similar with endocytology brush. Confocal laser endomicroscopy. Now, this is a novel technique that allows real-time microscopic imaging of the intracystic epithelium. Again, a mini probe is passed through the 19 gauge needle, and it allows high magnification and resolution of imaging of the cyst epithelium during EUS. So, there are different patterns which can be detected after fluoroscopic staining, and detection can be made on the basis of these patterns. This is not yet validated or translated into guidelines. So, combining all the guidelines, what is the broad treatment of all pancreatic cystic neoplasm? One by one. Serous cystic neoplasm. Does malignant SCN exist? Is there a malignant transformation? The answer is no. So, the indication in surgery is reserved in patients with symptoms related to compression of the adjacent organs. In patients who are not a candidate for surgery, the confirmed cases can be followed up to 1 year, and after 1 year, only symptom-based follow-up is recommended. Mucinous cystic neoplasm, indication for surgery if the MCN is more than 4 cm mural nodule is present, and the surgical procedure of choice will be determined by the degree of dysplasia. In IPMN, the indications of surgery include positive cytology, solid mass, jaundice, enhancing mural nodule, or a MPD diameter more than 10 mm. In this, the cyst size diameter was mentioned as 3 cm according to American guidelines. However, European guidelines suggest more than 4 cm, and the traditional Fukuoka classification does not include the presence of new onset diabetes mellitus, which have been incorporated in these guidelines. Now, coming to special populations. So, we all know that patients with family history of pancreatic cancer have an increased risk of developing pancreatic cyst. But does it hold true? Yes. But if you take follow-up of these patients, do they have increased chances of developing pancreatic cancer in the cyst? The answer to this is no. There is no difference in the risk of cancer in patients compared between pancreatic cyst with family history of pancreatic cancer versus pancreatic cyst without family history of pancreatic cancer. To summarize, this is my algorithm for management and evaluation. Whenever there is a cyst which is visualized on imaging, 3 questions need to be answered. 1, is it incidentally detected, or is the patient having any symptoms like obstructive jaundice, pancreatitis, solid mass. If yes, then patient needs to be referred for EVS FNA and for further multidisciplinary approach. If no, then what are the characteristics which are present? Answer these three questions. What is the main duct diameter? What is the cyst size? And is there any change in main duct caliber with upstream atrophy? Answer to this, if it is no, then you have to look at the largest cyst size. Depending upon the size, you have to do surveillance according to various guidelines, MRI being the preferred modality of choice. If there is a main duct involvement, cytology is suggestive of high-grade dysplasia or a mural nodule, then patient should be referred for surgery. One more thing to be noted, is radiological diagnosis sufficient enough to establish a diagnosis of PCN? So with this, I would like to conclude my presentation, and these are all the list of guidelines and studies and review articles which can be used for further reading. Thank you.
Thank you for a succinct crash course in cystic neoplasms. Difficult topic. You need a good radiologist, good sonologist, good endoscopist, good pathologist to be able to treat and manage. Do you have any information on machine learning algorithms which are coming up for diagnosis of cystic neoplasms?
Machine learning algorithm as in radiological?
Radiomics, yeah.
Radiological?
Yes, radiological, yes. And basically all the diagnostic modalities that you've put together can now be fed into a machine learning algorithm, which will give you diagnostic inputs for almost every single nodule that you can see on radio imaging.
Okay, okay, okay. So that is purely radiological. I don't have much idea about that, yeah.
Thank you, Siddharth, for a short, simple, sweet and superb talk. वो एमओसी ने अगर वो बोलेगा नहीं that you have been such a lovely audience और खुद के लिए तालियां बजाओ, तो मैं तो अच्छा एमओसी हूँ. So thank you, dear friends, and thank you, dear audience, for being overwhelmingly present on a Sunday morning going into evening. And या मुलाच्या हाके खातर इतके लोक धावून आले. It's a big achievement for him, and I'm very proud of him, what thing he has done. Thank you, dear chairpersons Manoj, Prakash and Dr. Mohan Sundaram for taking us through the last session so nicely. And now I invite you for lunch with or without soup. Thank you so much. And this is Dr. Prashant Bhandarkar signing off for the day and for the evening.